Good afternoon. Thank you for joining us. My name is Dr. Debra Patt, and I'd like to welcome you to the San Antonio Breast Cancer Symposium. I've had the privilege of being one of the conference organizers this year, and I'm so happy to moderate this session, which I proposed, which is to talk about controversies in local and regional management. I think this is really an important reason why a lot of people come to the conference, because these are questions that come up every day in Tumor Board. And as we have spent so much time in the medical oncology space thinking about where we need to escalate and where we need to de-escalate particular therapies, those, how patients respond have implications for other aspects of care like surgery, reconstruction, radiation, and the patient journey. And so I'm excited for this group of speakers to talk to you about that today. So they're each speaking about different aspects, and then we'll have a panel discussion. Please feel welcome to submit your questions, which we'll go through at the end, either at the microphones or you can submit them online. Starting out is Dr. Andrea Barrio from Memorial Sloan Kettering Cancer Center. Thank you for joining us.
Thank you so much. It is an absolute privilege to be here today, and today I'll be discussing challenging clinical scenarios in the management of the axilla. I have no disclosures. Management of the axilla was once very straightforward, where all patients were recommended for axillary lymph node dissection irrespective of nodal status, due to the Halstedian belief that breast cancer was a local disease and that the axillary node served as the nidus for distant spread of breast cancer. And in 1894, Halsted published a landmark publication where he reported outcomes in patients treated at Johns Hopkins. And in this paper, he wrote, "Everyone knows how dreadful the results were before the cleaning out of the axilla became recognized as an essential part of the operation." And most of us have heard our teachers in surgery admit that they have never cured a case of cancer of the breast. And he goes on to report the outcomes in patients treated with radical mastectomy and stated, in 43 of the 46 cases, there has been no true local recurrence. In other words, there has been a local recurrence in only 6%. And these statistics are so remarkably good that we are encouraged to hope for a much brighter, if not a very bright future for operation for cancer of the breast. Little did he know. This Halstedian belief was challenged and disproven by the randomized trial NSABP B04, which randomized patients to radical mastectomy versus total mastectomy with or without irradiation, and demonstrated no survival benefit to ALND in node-negative or node-positive patients. And while B04 did not result in the abandonment of axillary lymph node dissection due to the prognostic information that was used to guide systemic therapy, it did lay the groundwork for trials looking at less extensive axillary surgery. And in the mid-1990s, sentinel lymph node biopsy was introduced for node-negative patients, in 2010 for patients with limited nodal metastasis. We currently use neoadjuvant chemotherapy to downstage the node-positive axilla, and there are also ongoing trials now of omission of sentinel node biopsy. And this shift towards less extensive axillary surgery is driven by the desire to reduce morbidity and an understanding that tumor biology, and less so nodal status, determines prognosis and dictates treatment decisions. And so why is axillary management so complicated? Because there are really diverging views on the topic. There are some that believe that ALND is bad. We all have a desire to avoid surgical complications, but many are convinced that lymphedema is inevitable after ALND and that ALND is never beneficial. But there are those of us that understand that ALND is necessary under certain circumstances and that nodal status is still important for many systemic therapy decisions, that nodal recurrence in patients with advanced disease treated without ALND is unknown, resulting in a fear of undertreatment. And because of these diverging views, there's a wide variation in clinical practice in how the axilla is managed. And those that believe ALND is never beneficial inappropriately extrapolate data to provide justification for ALND avoidance in unproven or high-risk clinical scenarios. So today we're going to discuss these challenging clinical scenarios in the management of the axilla in the upfront surgery setting and after neoadjuvant chemotherapy. I will not be discussing omission of sentinel node biopsy, as this will be discussed by Drs. Morrow and Giuliano tomorrow. So ACOSOG Z11 and AMAROS randomized patients with clinical T1 to 2 N0 breast cancer with 1 to 2 positive sentinel nodes to ALND versus no axillary surgery in Z11 or ALND and nodal RT in AMAROS, and demonstrated no difference in 10-year axillary recurrence and no difference in disease-free survival or overall survival. All patients in Z11 had lumpectomy, and the large majority in AMAROS got treated with lumpectomy as well. And since most lumpectomy patients are treated with radiotherapy, significant treatment escalation is not needed to avoid axillary lymph node dissection. So why are mastectomy patients managed differently? Well, not all mastectomy patients with a positive sentinel node need PMRT, and therefore ALND would be indicated. There's also a desire to avoid unnecessary PMRT simply to treat the undissected axilla because of the morbidity associated with treatment. And obviously our goal is to avoid doing both ALND and PMRT in patients with limited nodal disease. So how do we manage micrometastases? IBCSG 2301 and AATRM randomized patients with sentinel node micrometastases to ALND versus sentinel node biopsy and demonstrated no difference in nodal recurrence rates. But notably, there were a very limited number of mastectomy patients enrolled on trial. So due to the underrepresentation of mastectomy patients in the randomized trials, the aim of the CENEMIC trial was to study the safety of omission of ALND in patients with sentinel node micrometastasis, including mastectomy patients. This was a single-arm prospective multi-center cohort study that enrolled patients with sentinel lymph node micrometastases. Patients did not have ALND, and PMRT was at the discretion of the treating physician. 566 patients with sentinel node micromets were enrolled, 217 had a mastectomy without ALND, and about a third received PMRT. And at a median follow-up of 38 months, there were 5 isolated axillary recurrences observed, a slightly higher rate in mastectomy patients, 1.8% versus 0.3% in lumpectomy patients. And notably, recurrences were more common in patients treated without radiotherapy. And so given the excellent outcomes, these findings support the safety of omission of ALND in patients with micrometastasis in the sentinel node undergoing mastectomy. And given the low rate of axillary recurrence, I would argue that PMRT is likely unnecessary, although longer follow-up is needed. So how do we manage patients with sentinel node macrometastasis? This approach varies depending on the number of positive sentinel nodes. In patients with 3 or more positive sentinel nodes, the Ontario Health and ASCO guidelines recommend the use of both ALND and regional nodal irradiation, and that is our standard at MSK. But in patients with 1 to 2 positive sentinel nodes, typically ALND or nodal RT is recommended, and the use of both likely represents overtreatment. AMAROS and ODOAZAR randomized patients with 1 to 2 positive sentinel nodes to ALND versus nodal RT, and again demonstrated no difference in nodal recurrence. About 17% of patients in each study were treated with mastectomy. And so these findings suggest that nodal RT is an appropriate alternative to ALND in patients undergoing mastectomy with 1 to 2 positive sentinel nodes, provided that PMRT is indicated. And the criteria for PMRT among patients with 1 to 2 positive sentinel nodes is not standardized in the United States and in many countries around the world. And current NCCN guidelines recommend to strongly consider RT to the chest wall and regional nodal irradiation in mastectomy patients with 1 to 3 positive nodes, but provide no further criteria as to how to guide this decision-making process. And so at MSK, we developed criteria for PMRT in clinically node-negative patients having upfront mastectomy with positive sentinel nodes, and we incorporated high-risk clinical pathologic features that are known to increase the risk of locoregional recurrence. And the goal of the guideline was to avoid overtreatment with combined ALND and PMRT in patients with 1 to 2 positive sentinel nodes. But a notable limitation is that much of the pathologic information needed for decision-making is not available intraoperatively. And so at MSK, my colleague Anita Mamtani looked to assess the impact of omission of sentinel node frozen section on axillary overtreatment. She identified 2,200 patients treated with mastectomy. They had clinical T1 to 3 N0 breast cancer, and about 267 or 12% had 1 or more sentinel node macromet. Half of those patients, or 141 patients, had 1 to 2 positive sentinel nodes and met PMRT criteria and could have avoided ALND had sentinel node frozen section been omitted. The remaining patients required ALND due to the presence of 3 or more positive sentinel nodes or 1 to 2 positive sentinel nodes not meeting PMRT criteria. But overall, this represents a very small percentage of the entire cohort that would have had to return to the OR for ALND. And so deferring sentinel node frozen section reduces axillary overtreatment and minimizes morbidity and is our standard at MSK. But trends in axillary management in mastectomy patients with 1 to 2 positive sentinel nodes is quite variable. And we can see here in this study looking at the NCDB database, looking at over 4,000 mastectomy patients with 1 to 2 positive sentinel node macromets, that the management of the axilla is quite variable. And 28% of patients receive both ALND and PMRT, and probably more concerning is that 17% didn't get any treatment at all. In a national survey of breast surgeons, 680 surgeon respondents were asked how they managed the axilla in mastectomy patients, and 52% stated that they routinely performed frozen section on sentinel nodes during mastectomy, and 78% perform ALND if the sentinel node is positive. And so this really provides us with a significant opportunity to avoid axillary overtreatment by simply omitting routine frozen section in the upfront mastectomy setting. So are there patients in whom we can omit all or any axillary treatment? And this is being studied in multiple trials, but I'm going to discuss 2 here. The Synodar 1 trial enrolled patients with T1 to 2 breast cancer undergoing lumpectomy and mastectomy with 1 to 2 positive sentinel nodes. They recently published their outcomes data in the mastectomy cohort. They had 218 patients that were randomized to ALND or sentinel node biopsy. Only 8% got PMRT, and at a median follow-up of 33 months, there were no axillary failures. But due to the small numbers, Synodar 1 has reopened to mastectomy patients and enrollment is ongoing. The Posnock trial enrolled patients with 1 to 2 sentinel node macromets undergoing lumpectomy or mastectomy to adjuvant therapy alone or adjuvant therapy plus nodal clearance or nodal RT, and these results are expected in July of 2026 and will guide us as to which patients can avoid axillary therapy. But until then, there is insufficient data to support omission of ALND and PMRT in patients with 1 to 2 sentinel node macrometastasis. What about patients with 3 positive sentinel nodes? Well, as we can see from these trials here, very few of those patients had 3 or more positive sentinel nodes, and there's no high-level data on local control for the undissected axilla in patients with 3 or more positive sentinel nodes. But currently, the ASBRS consensus statement on axillary management actually states that sentinel node without ALND is appropriate for patients undergoing mastectomy with 1 to 3 positive sentinel nodes, but they note that the data for 3 or more positive sentinel nodes may be insufficient, and I agree. ALND remains the standard of care for clinically node-negative patients undergoing lumpectomy or mastectomy with 3 or more positive sentinel nodes. The good news is this is being currently studied in a randomized trial in the ENSEMA trial, which has completed accrual. The primary endpoint of ENSEMA was to look at the oncologic safety of omission of sentinel node biopsy. Patients, they enrolled over 5,000 patients with clinical T1 to 2 N0 breast cancer undergoing lumpectomy, and these patients were randomized in a 4-to-1 fashion to sentinel node biopsy or none. And in the patients that had sentinel node biopsy, patients with 1 to 3 positive sentinel nodes underwent a second randomization to sentinel node biopsy alone versus ALND. These results are expected in December 2024 and will help us understand if we can omit ALND in patients with 3 positive nodes. How do we manage the clinically node-positive axilla? Well, patients with HER2 positive and triple negative subtype are recommended for neoadjuvant chemotherapy to downstage their axilla. But in patients with hormone-positive, HER2-negative breast cancer, rates of nodal PCR are low. They range from 18 to 21% with chemo and 5 to 14% with endocrine therapy, resulting in high rates of ALND. Currently, ALND is the standard of care for clinically node-positive patients having upfront surgery, but is there an opportunity to do less? Sentinel node biopsy as a strategy to manage the clinically node-positive axilla can only be considered if the nodal burden in clinically node-positive patients is low, allowing patients to be managed according to Z11, if the sentinel node identification rate is high, and if sentinel node biopsy is accurate. And so in order to assess the nodal volume in patients with palpable adenopathy at MSK, we looked at our cohort of patients with clinical T1 to 3 N1 breast cancer, hormone positive, HER2 negative, and identified 180 that were having upfront surgery. And 43% of these patients had limited nodal disease, only 1 to 2 positive nodes on ALND. And these findings suggest that nearly half of clinically node-positive women could be managed according to Z11 if the sentinel node biopsy is accurate. And so we currently have an ongoing prospective trial, also led by Anita Mamtani, enrolling patients with clinical T1 to 2 palpable N1 hormone-positive HER2-negative breast cancer. These patients are all having an in-house ultrasound to make sure they don't have extensive nodal disease. And if they meet eligibility criteria, they undergo a sentinel node biopsy. If they have only 1 or 2 positive sentinel nodes, ALND is omitted. And if they have 3 or more positive sentinel nodes, the initial clipped node is not retrieved or they fail to map, they undergo ALND. And just to give you a quick study update, accrual began in April of 2021 with a target accrual of 78 patients. We have 52 patients enrolled. 81% have undergone sentinel node with dual tracer mapping, 19% with single tracer, and our identification rate of the biopsy-proven node is 100%, and all patients had a minimum of 3 sentinel nodes removed. And so when we have data on ALND avoidance, this will be presented when the study completes accrual, but clearly this demonstrates that sentinel node biopsy is feasible in this population. So switching to the neoadjuvant setting, we're all familiar with these 4 prospective trials that studied the sentinel node feasibility in clinically node-positive patients, demonstrating a false negative rate that exceeded 10%. But with the use of dual tracer mapping and removal of 3 or more sentinel nodes, the false negative rate uniformly fell to below 10%. And since then, there have been multiple studies evaluating nodal recurrence rates in clinically node-positive patients who achieved nodal PCR and were treated with sentinel node alone. And all of these studies demonstrated extremely low nodal recurrence rates, and I will highlight the study at the bottom, which was presented last year by my colleague Dr. Montagna at San Antonio, of over 1,100 patients, and at a median follow-up of 42 months, the nodal recurrence was 1%. But we know that not all patients achieve nodal PCR, and that this nodal PCR rate varies by receptor subtype, with the lowest in hormone-positive HER2-negative patients. So in patients with residual disease after NAC, how should we manage the axilla? We know that rates of non-sentinel node positivity in patients with a positive sentinel node after NAC are uniformly high across all studies, ranging from 61 to 72%, much higher than we see in the upfront surgery setting. And we also know that the likelihood of non-sentinel node positivity does not vary based on the size of the nodal met. Whether a patient has a micrometastasis in the sentinel node or a macrometastasis, the likelihood of non-sentinel node positivity exceeds 60%. And also the data on nodal recurrence in patients with residual disease treated with sentinel node alone is limited. There's very few patients in these studies, and the nodal recurrence rates are variable. So outside of a clinical trial, patients with residual disease in the sentinel nodes should be treated with ALND. But as we know, people are still doing sentinel node, and if we look at real-world data at the NCDB database, over 30,000 patients treated with NAC. Of patients who had a sentinel node biopsy on the left, a third of them had residual nodal disease and did not have ALND. And on the right, Dr. Bowie recently published axillary treatment trends in patients from the I-SPY 2 trial, and of patients with residual disease in the nodes after chemo, the use of sentinel node only increased from 6.9% to 39.2% in 2021 without any oncologic safety data to support this practice. So we anxiously await the results of the ongoing randomized trials, and there's a 3rd trial from Spain I did not include here, randomizing patients with a positive sentinel node after NAC to either ALND plus nodal RT or nodal RT alone. And until then, axillary dissection is the standard. How about for patients with locally advanced breast cancer, sentinel node biopsy? There's limited data. There's 4 studies looking at sentinel node biopsy in inflammatory breast cancer with low identification rates and unacceptably high false negative rates. And in others, clinical T4 or N2, N3 disease, the numbers are very small looking at sentinel node in these cohorts. But again, we see an increasing use of sentinel node biopsy in locally advanced breast cancer. In the study on the left, looking at the NCDB, an increasing use of sentinel node in clinical N2 and N3 disease, 22% in 2012 after neoadjuvant chemo. I'm sure that's much higher now. And in inflammatory breast cancer, looking at the NCDB database of over 1,000 patients, 22% in 2017 were treated with sentinel node biopsy. The good news is these patients seem to have an excellent response to systemic therapy with modern systemic chemotherapy. And looking at this study from MSK and MD Anderson, we see that nodal PCR rates are high in patients with locally advanced breast cancer, particularly in HER2-positive cancers receiving HER2-directed therapy. And given these high nodal PCR rates, sentinel node biopsy would be appropriate if the identification rate is high and if sentinel node biopsy accurately predicts the status of the axilla. And so at MSK, we have a study looking at sentinel node biopsy in patients with locally advanced breast cancer, which I'm the principal investigator. We're enrolling patients with clinical T4, N2, N3, who become clinically node negative after NAC. They will undergo sentinel node biopsy with a backup dissection, and our primary objective is to prospectively determine the false negative rate of sentinel node in these patients. So a study update, accrual began in 2017. Our target accrual is 150 patients. We've enrolled 114, and as you can see from this figure here, just about 50% are inflammatory breast cancer patients, and the other half are other clinical T4, N2, N3. 109 have completed surgery, and the nodal PCR rate is very high at 45%. We anticipate that we'll complete accrual in the next 12 to 18 months, and when we do, we will present data on identification rate and false negative rate. So to summarize axillary management, who can have a sentinel node biopsy? Patients with micrometastasis, whether they're having a lumpectomy or mastectomy. Patients with 1 to 2 positive sentinel nodes undergoing lumpectomy or mastectomy if PMRT is indicated. Clinically node-positive patients with a nodal PCR after NAC. Which patients still need an ALND? Patients with 3 or more positive sentinel nodes, or mastectomy patients with 1 to 2 positive sentinel nodes not meeting PMRT criteria. Clinically node-positive patients having upfront surgery. Patients with residual disease in the sentinel node after neoadjuvant chemo, no matter how small the nodal deposit, excluding ITCs. Patients with locally advanced breast cancer, irrespective of their response to NAC. And so I would argue that we should not omit ALND in patients without high-level evidence supporting the oncologic safety of omission simply to decrease the risk of lymphedema, and instead we should consider alternatives to minimize lymphedema. In this randomized controlled trial from Tata Memorial Hospital, patients treated with ALND were randomized to a compression sleeve versus none, and there was a significant reduction in lymphedema rates at 1 year with the use of compression garments. In the study on the right from MSK, patients were randomized to lymphatic reconstruction versus none, and again, at 1 year, a significant reduction in lymphedema rates. And so in conclusion, management of the axilla has evolved significantly over time towards less extensive surgery due to improvements in systemic therapy, radiation, and the understanding of tumor biology. While many patients with limited nodal disease can safely be treated without ALND, there remains a proportion of patients in whom ALND is still indicated due to a lack of data on oncologic safety, and we await findings from ongoing clinical trials to provide us with evidence regarding the safety of omission of ALND in high-risk patients with more extensive nodal disease. And I thank you.
Such an excellent overview. Thank you, Dr. Barrio. Next, we're going to talk about when less is more, patient-friendly radiation courses with whole breast irradiation and partial breast irradiation. This is Dr. Icro Meattini from the Università degli Studi di Firenze in Florence, Italy.
Thank you very much for the introduction, and these are my disclosure. Maybe, yeah. Related to grant and trials involvement and recommendation concerning the topic. So, first of all, I really appreciate the title, so the patient-friendly, and I ask myself what is a reasonable definition of patient-friendly in a very low-risk breast cancer patient. So, first of all, minimizing treatment toxicity burden, decreasing the stress for patient, reducing, of course, the financial strain, saving time, carrying expectations of health-related quality of life, so please prioritize patients' well-being, addressing health-related quality of life, and definitely to survive is patient-friendly. So basically, early breast cancer, I think that could be a paradigmatic example of a perfect integration of a multidisciplinary and multifactorial knowledge in a patient-oriented perspective. So Where we start, this is my overview today, whole breast and partial breast irradiation, when less is more. First of all, less fractions. I think that we have got a level 1 evidence, and debate is definitely close in terms of moderate hypofractionation. Here you can see the main data and the main local relapse rates published on the randomized trial testing hypofractionation, moderate hypofractionation after breast conserving surgery in early breast cancer, especially 42 in 16 and 40 gray in 15 fractions, as you can see, so you know very well. If you look at the cumulative risk of locoregional relapse in terms of efficacy, there is no difference when you compare the 40 gray in 50 fractions with the 50 gray in 25 fractions. And of course, there's no impact in terms of disease-free survival. These are the results published by the START-B trialists, and also in terms of mortality. This is very nice graph published by the Danish breast cancer group, IPO trial, that put in relation all the cause of mortality, and there's no difference if you use a moderate hypofractionation treating breast cancer after breast conserving surgery. What about safety? Of course, we discussed a lot over the last decades about safety using moderate hypofractionation. As you can see, there's no differences in terms of main late normal tissue effect. These are data reported by the START-A and B trials. And if you look at the grade 2 and 3 in durations reported by the Danish breast cancer group IPO trials, of course, there's a significant advantage in favor of hypofractionation as compared to conventional fractionation. And if you look at the meta-analysis of severe or moderate severe physician-assessed normal tissue effects as then compared with 50 gray in 25 fractions reported by the START trialists, there's no subgroup specific features related to a favorable impact of conventional fractionation. So look at the age, the breast size, the use of boost, tumor bed boost, adjuvant chemotherapy, or tamoxifen, always in favor of moderate hypofractionation. So this is at least standard of care. But we can even go towards less fractions. So the next step was the ultra hypofractionation of the 5-fraction whole breast irradiation. A lot of discussion around the fast forward trial published 3 years ago, first name Mary Brandt and colleagues from the UK, that compared 26 gray and 27 gray in 5 daily fractions as compared to the standard of care, so 40 gray in 15 fractions over 3 weeks. These are the main findings published at the median follow-up of 6 years. If you can see, there's no differences in terms of local relapse, 1.4% for the 26 gray as compared to 2% in the 40 gray, and similar assessment concerning late normal tissue effects. So these are the major findings. Ultra hypofractionation, at least 26 gray in 5 fractions, show non-inferior local control rates and similar safety profile when compared to the standard care of 40 gray in 15 fractions. But look at the discussion that go deeper. These are the clinician and patient assessment of adverse events up to 5 years published by the authors. At 5 years, if you compare any clinician assessed moderate and marked adverse events, you can see 10% for the 40 gray in 15 fractions as compared to 12% in the 26 gray. And if you look at the late odd ratios from 1 to 5 years concerning moderate marked adverse events, again, the odd ratio is 1.12, so no difference if you use a 5-fraction schedule. It's really important to look at the difference concerning the relative treatment effect, as you can see in the main publication, in duration, as was the only factor statistically significant in favor of 40 gray as compared in the 26 gray. But if you look at the absolute treatment effects for our patient, this is really patient-friendly. I mean, you can really catch the magnitude of effect that is crucial to determine when something is clinical significant. So, for example, the breast chest wall edema published in the fast forward trial, and thank you very much, my colleague Charlotte Coles, showed that the moderate and severe breast chest wall edema was 1%, both for patients receiving moderate hypofractionation and patients receiving 26 gray in 5 fractions, so really not clinically relevant. So, basically data supporting hypofractionation, at least moderate hypofractionation, is available for a long time. You know, we are radiation oncologists, we need time, but I think there's no reason not to consider at least moderate hypofractionation and as standard of care for our patient. And all the recommendation, both in UK, European and American recommendation, already consider moderate or ultra hypofractionation and potential standard of care. Only the NCCN recommendation still consider 25 fraction as a potential option for these patients. But things are moving forward, and we published last year together with the Acro consensus statement the recommendation concerning whole breast irradiation and fractionation. So moderate hypofractionation whole breast irradiation should be offered regardless of any features, so age, stage, cancer biology, marginal status, use of boost, size, the presence of DCIS component, the use of oncoplastic conserving surgery, of the use of systemic therapy, and where there is a consensus, ultra hypofractionated radiotherapy 26 gray in 5 fractions can be offered as standard of care of at least used within a randomized control trial or a prospective registration cohort. So, partial breast irradiation. No, before some consideration over the tumor bed boost, because when we want to really be patient friendly, we can consider a less total dose. These are the main results published at a longer follow-up by the Boost No Boost trial, over 5,000 patients and a median follow-up of more than 70 years. These are the well-known results. Tumor bed boost has no effect on overall survival, but improves local control. Of course, this led to higher risk of moderate or severe fibrosis, but where is the largest absolute benefit of using a boost? So if you take into account the balance between the effectiveness of radiotherapy and the impact of toxicity, look at the curves of the cumulative incidence of ipsilateral breast tumor recurrence by age and the curves of the cumulative incidence of severe fibrosis by age. It's clear that the largest absolute benefit is in younger patients aged less than 60 years. So please select your patient when you decide to use a tumor bed boost. Also because we know very well the predictors for poor cosmetic outcome. These are the results published by the Young Boost trial that use 2 different boosts, 16 gray or 26 gray tumor bed boosts, was evident some specific features associated with a poorer cosmetic outcome, the kind of energy that you use for whole breast irradiation, so where this places basically the tumor, and higher boost dose is associated to a really poorer cosmetic outcome. It's really important that baseline cosmetic assessment. The largest boost volume, some use the guidelines to contour and delineate your boost in order that the volume is lesser, and the use of adjuvant chemotherapy. So now partial breast irradiation. If we want really give less, when less is more, first of all, less treated volume. In general terms, we know very well that we now have more than 10,000 patients that have been enrolled and randomized in controlled trial, and we have got long-term results of patients randomized to receive partial breast and whole breast irradiation that focus on multiple concepts, both the ipsilateral breast tumor recurrence, dose and fractionation regimens, trying to provide an optimal control and minimize toxicity. Of course, patient selection for partial breast irradiation and then criteria was the big challenge over the last decade. So moderate fractionation for partial breast irradiation, this is the UK import law trial, something about efficacy and safety. More than 90% were stage 1 hormone receptor positive, HER2 negative, treated with 40 gray in 15 fractions external beam radiotherapy. Published at 5 years, no differences in terms of ipsilateral breast tumor recurrence, and as expected, not impact on distant metastasis and overall survival. And this trial has been presented during the last ASTRO meeting here in United States by Anna Kirby, first author, showing that the primary endpoint of ipsilateral breast tumor recurrence is confirmed, so no differences in terms of local recurrence at a longer follow-up, and an advantageous safety results results in favor of partial breast irradiation. If you look at the anytime moderate mark clinician assessed breast normal tissue effect in the patient. So equivalent control, less toxicity for our patients. Because volume matters, and this is really an extremely smart publication by the Danish group that primary endpoint, the PBI, Danish Breast Cancer Group trial, primary endpoint cumulative incidence of grade 2, 3 in duration at 3 years and a half. So that is the main results. Whole breast irradiation led to, of course, a higher grade 2, 3 in duration as compared to partial breast irradiation, especially in large breast size. And this is very nice companion publication in the Green Journal that show how the frequency of grade 2, 3 in duration is really related to the volume irradiated. There is a clear increase with the volume of breast tissue irradiated to 40 grade, favoring, of course, the use of partial breast irradiation. Why not to go to less fractions and not only to less volume irradiated? So accelerated partial breast irradiation. One of the first published trials was the Jack-Estro trial using brachytherapy high-dose rate in 7-8 fractions. More than 1,000 patients affected with very low risk breast cancer, and these are the main results. Again, no differences in terms of local control and no impact in the main outcome, both survival and distant metastasis, even at the updated and published 10 years results. So very long-term results, no differences in terms of local control and survival outcome. And in the favorable impact, again, in favor of partial breast irradiation delivered using brachytherapy high-dose rate concerning acute and late toxicity, especially skin toxicity. So again, equivalent control and better adverse events. If you want to use an external beam approach, you can use the Florence trial, 30 grain, 5 non-consecutive fractions, accelerated partial breast irradiation using an intensity modulated radiation therapy techniques. We presented here in San Antonio, so we really love this meeting at all. And we published then the 10 years follow-up, so long-term follow-ups. Again, we show no differences in terms of local relapse, less than 4% in both the arm cohort, and no impact in terms of breast cancer specific survival and other specific outcome, survival outcome at 10 years median follow-up. But also we show a significant impact, favorable impact concerning partial breast irradiation, both concerning the acute and late period towards the observation time, and physician and patient rated cosmesis in favor of partial breast irradiation. Some years ago, we presented some data also concerning quality of life, and we move to the new current technique. We move from a MRT to a partial arc VMAT technique in order to reduce treatment delivery time and improve dose distribution, and we move from a non-consecutive to a consecutive schedule, so using just 1 week of treatment, and we recently published our preliminary experience. Concerning quality of life, we presented during the last European Cancer Congress in Amsterdam years ago the impact of partial breast irradiation delivering 30 grain 5 fractions that favorably impact all the functional scale concerning the general quality of life questionnaire from ERTC. The symptom scales always favor partial breast irradiation, and also the breast cancer related module symptom scales. And if we look at the global health status, so how to try to find the magnitude of this impact, you can see how partial breast impact over time over whole breast irradiation, both if we use the highly discussed 5-point thresholds of 10-point threshold of clinically significance in terms of global health status. So equivalent control, better safety, better cosmesis, and better quality of life for our patients. Some comments about the trials testing twice daily fractionation. These are 2 amazing trials presented here in San Antonio years ago, the B39 and the RAPID trial. The B39 was a great trial, unfortunately did not meet the primary endpoint, but please look the 10-year difference in terms of ipsilateral breast tumor recurrence, less than 1% at 10 years between arms, so really not clinically relevant. And the RAPID trial using external beam radiotherapy accelerated partial breast irradiation, both 3-dimensional and MRT, met its primary endpoint, so no difference at 5-year and 8-year in terms of ipsilateral breast tumor recurrence, but unfortunately there was some specific concern in terms of not acute toxicity, because it's favorable for partial breast irradiation, of course, but in terms of late toxicity. So this is related to the twice daily fractionation. And of course, there was an absolute difference, poorer difference in terms of cosmesis. And be careful not to go too fast. These are the very first trials testing partial breast irradiation as compared to whole breast irradiation. It's nothing related to the technique. The technique used is basically something related to the patient selection, because really patient selection is the key in our patients and in our treatment. Patient selection and radiation therapy in general is not a one-size-fits-all treatment. But now we have got the recommendation how to well select patients that should be candidate to receive partial breast irradiation. These are the Acro 2022 consensus statements. So luminal-like subtypes, small tumors less than 3 centimeters, no lymphovascular invasion, not lobular invasive carcinoma, tumor grade 1 to 2, even low to intermediate grade DCIS for patient age more than 50 years, unifocal lesion, clear surgical margins, not negative, not use of primary systemic therapy. These patients should receive partial breast irradiation over whole breast irradiation. And the Astro Clinical Practice Guidelines has been just published last week. So these are the indication for partial breast irradiation as an alternative to whole breast irradiation. And we are basically in agreement. Europe and America are basically saying the same thing. So partial breast recommended for early invasive breast cancer with all the following: grade 1 to 2, year positive, age even more than 40, although there's a moderate quality of evidence, but of course strong for patient age more than 50, tumor size less than 2 centimeters. Again, partial breast is also recommended for patients with DCIS with all the following: low to intermediate, age more than 40 years, size less than 2 centimeters. Concerning dose and fractionation, the European guidelines, of course, these are the recommendation. Moderate hypofractionation, so 40 grain 15 fractions, or ultra hypofractionation between 26 and 30 grain 5 fractions represent acceptable schedule to deliver external beam partial breast irradiation. Twice a daily external beam partial breast irradiation, as I showed you before, should not be used as primary choice for these patients. And the echoing by the Astro Clinical Practice Guideline, these are the appropriate dose fractionation regimens, target volumes and planning parameters, external beam partial breast, 30 grain 5 once daily fraction delivered on non-consecutive days within 2 weeks, 40 grain in 15 once daily fractions over 3 weeks, or high dose rate brachytherapy as published by the main phase 3 trial. Concerning the appropriate technique with respect to toxicity and cosmesis, once daily external beam partial breast based on fever-related toxicity and improved cosmesis, 40 grain 15 fractions, multi-catheter brachytherapy, and again, twice daily external beam radiotherapy, not recommended as primary choice. If you like to move forward fast, you can do it using the fast forward, taking account that in UK, 26 grain 5 fractions is already standard of care to deliver partial breast irradiation, although in absence of a specific phase 3 trial. So coming to my final consideration, just imagine for the last 5 minutes and enough that the title of my talk wasn't when less is more patient-friendly radiation courses, but just when less is not enough yet. So we have to talk about whole breast irradiation omission. This is a great study that has been published some months ago of patients, single course, 500 patients, PT1 and 0, estrogen receptor positive, low Ki67, less than 13%, that omit radiation therapy with an assumption of less than 5% at 5-year local relapse. And these are the main results. Local relapse after 5 years in this cohort is 2.3%. 30% with a favorable impact in terms of disease-free survival and overall survival. But there are still some open questions, so the quite broad inclusion criteria taking account that 40% of patients were less than 65 years old, that this is of course relevant to life expectancy, the impact of Ki-67, that of course the impact and the relation with the use of genomic testing in this gray area, the interreliability of this threshold. So basically, if we want to answer the question of the effectiveness of radiotherapy on local relapse, we should look at the PRIME2 study, that is a great phase 3 trial that been published 2023, again, a long-term follow-up. So what happens to these patients when you omit radiation therapy? Basically, the overall course show at 10 years that the patient recurrence 10% as compared to 1%. If you look at the estrogen receptor low, that's just below 50%, this local relapse rate increased to 20% of patients not receiving radiotherapy as compared to 0% in patients receiving breast conservative surgery and radiation therapy. So these are the optimization trials for early low-risk breast cancer. Omission radiotherapy is still investigation. We are not there yet. Of course, this is the main phase 3 trial, all of them taking account age, the stage, the biology of tumor, but also as primary endpoint, look at, for example, the Europa trial, not only the local relapse, that for patients, this very low-risk patient, maybe it's not the primary endpoint, but also health-related quality of life as primary endpoint. Because we need really some considerations also over endocrine therapy, adverse events and treatment compliance. Remember that radiotherapy de-escalation is not the only existing optimization strategy for these patients. We all know the safety profile of endocrine therapy and the problem of compliance of patients. It is estimated that a lot of patients during the planning course will discontinue the endocrine therapy due to several reasons. So, coming to my conclusions, when less is more, patient-friendly radiation courses with using whole breast and partial breast irradiation. Towards less, no radiation therapy probably currently is still the wrong answer to the right question to be investigated. Toward less, lower dose, please use a proper patient selection to omit tumor bed boost. Toward less fractions, nothing to say. Standard of care hypofractionation for all patients, 15 fractions or 5 fractions. Toward less target volumes, partial breast irradiation. If you follow a proper patient selection, partial breast irradiation should be the preferred option over whole breast irradiation. And of course, a risk-adapted radiotherapy recommendation. Genomic profiling, please follow tomorrow morning IDEA trial cohort results using a genomic also profiling. That is clearly the future, though still investigation. I would like to thank all my great colleagues that made all this possible and my team at the University of Florence and you for the kind attention. Thank you very much.
Thank you so much for that excellent talk. Next, we'll have Dr. Anita Mamtani from Memorial Sloan Kettering Cancer Center discuss surgical management of stage 1 triple-negative and HER2-amplified breast cancer.
Perfect. Thank you for the introduction, and I thank the Planning Committee for the invitation to speak. I will be discussing treatment strategies in stage 1 triple-negative and HER2-positive breast cancer with a focus on optimizing the surgical management of the axilla. I have no financial disclosures. This subject poses a unique modern treatment dilemma in a time where neoadjuvant chemotherapy is increasingly used in the treatment of early-stage triple-negative and HER2-positive disease. This is because randomized trials show high rates of pathologic complete response, as well as improvements in disease-free survival and overall survival with tailoring of adjuvant therapies if PCR is not achieved. The benefit is very clear in stage 2 disease, but stage 1 patients comprise a very small minority in these trials, and the optimal treatment approach in the stage 1 population remains controversial. Despite this, the use of neoadjuvant chemotherapy in the stage 1 population is increasing. In this study from the National Cancer Database, including over 55,000 triple-negative patients treated between 2014 and 2019, the rate of neoadjuvant chemotherapy increased from 20% to 34%. This increase was noted in both the T2 and T1C subsets, with nearly a quarter of T1C patients receiving neoadjuvant chemotherapy by 2019. Similar trends have also been seen in the HER2-positive population. In this study from the National Cancer Database, including 15,000 HER2-positive patients, the rate of neoadjuvant chemotherapy increased from 4% to 17% between the years of 2010 and 2015. This increase was largely attributable to the T1C subset, which saw the greatest annual percent change of 38%. But why the debate? Neoadjuvant chemotherapy regimens may confer risks of chemotherapy and immunotherapy-associated toxicities without proven benefits from an adjuvant therapy switch in stage 1 patients who do not achieve a PCR. In addition, de-escalated adjuvant therapy regimens do have excellent outcomes in pathologic stage 1 disease. So surgical downstaging therefore becomes an impetus for considering neoadjuvant chemotherapy. While management of the breast is rarely altered by tumor downstaging of T1 disease, the treatment of occult axillary disease in these chemoresponsive subtypes may be proposed as a rationale for considering neoadjuvant chemotherapy. To address the nuances relevant to this debate, I will first review the data supporting neoadjuvant chemotherapy in early-stage triple-negative and HER2-positive disease, followed by de-escalation opportunities in the stage 1 population, and then review the nodal disease burden among clinical stage 1 patients, followed by the need for axillary dissection in the triple-negative and HER2-positive subsets. There is compelling support for neoadjuvant chemotherapy in stage 2 disease due to improvements in PCR rates and the benefit from chemotherapy switch if PCR is not achieved, but data is lacking in the stage 1 population. Listed here are landmark studies carried out in the triple-negative and HER2-positive populations, which comprise the bulk of this literature. The CREATE-X trial included 887 patients that were HER2 negative and did not achieve a PCR after neoadjuvant chemotherapy. They were randomized to receive either adjuvant capecitabine or placebo. 286 patients in this study were triple negative, and significant improvements in disease-free survival with a delta of nearly 14%, and an improvement in overall survival with a delta of 8.5% were noted in the triple-negative subset with capecitabine. Importantly, only 38 stage 1 patients were included in this study, comprising less than 5% of the trial population. The more recent I-SPY 2 and Keynote 522 trials have evaluated and established a role for immunotherapy in the treatment of early-stage triple-negative disease. The I-SPY 2 is among the early phase 2 trials that showed that the addition of pembrolizumab to standard neoadjuvant chemotherapy improved rates of PCR in triple-negative patients from 22% to 60%. The Keynote 522 trial evaluated 1,100 patients who were randomized to receive either pembrolizumab and neoadjuvant chemotherapy or standard neoadjuvant chemotherapy, followed by surgery, after which patients in the pembrolizumab arm continued on with 9 cycles of maintenance. There was a significant improvement in 3-year event-free survival in the pembrolizumab arm at a rate of 85% as compared to 77%, but importantly, the greatest benefit here was seen among node-positive patients. Of note, only a single stage 1 patient was included on this trial. Switching gears to the HER2-positive population, multiple early studies have shown that there is a value to neoadjuvant chemotherapy and trastuzumab in stage 2 to 3 HER2-positive disease, and the prognostic value of PCR is well known. More recent studies listed here have shown that the addition of pertuzumab further increases the rates of PCR. As a result, since its approval for this indication in 2013, the use of dual HER2 blockade has become standard for neoadjuvant HER2-positive regimens. However, 0 stage 1 patients were included in these studies, leading NCCN and other guidelines not to endorse the routine use of neoadjuvant pertuzumab in clinical stage 1 disease. Finally, the most recent Catherine trial evaluated 1,500 HER2-positive patients who did not achieve a PCR to neoadjuvant chemotherapy, who were randomized to receive either adjuvant trastuzumab or switched to TDM1. there was a significant improvement in 3-year disease-free survival with the switch to TDM1 at a rate of 88%, as compared to 77% with trastuzumab. But importantly, only 67 stage 1 patients were included, again comprising less than 5% of the trial population. In sum, these landmark studies, which have certainly shaped many of the neoadjuvant treatment algorithms for triple-negative and HER2-positive disease, included very few stage 1 patients. They comprised less than 5% of the trial populations, making the applicability of these results somewhat difficult for the stage 1 subset. In addition, high-quality evidence supports the de-escalation in pathologic stage 1 disease. In subset analyses of the aforementioned CREATE-X trial, 129 clinical T1 patients with any end stage were examined, along with 347 node-negative patients with any T stage. When comparing those who received capecitabine to those who did not, there were no significant gains in disease-free survival or overall survival seen, suggesting that there is no benefit from capecitabine in clinical T1 or pathologically node-negative triple-negative tumors. Retrospective studies also show similar survival outcomes when comparing neoadjuvant chemotherapy to adjuvant chemotherapy in stage 1 triple-negative patients. In this study from the National Cancer Database, including over 48,000 patients treated from 2006 to 2016, there were similar 5-year rates of overall survival with adjuvant chemotherapy at a rate of 91%, as compared to neoadjuvant chemotherapy at a rate of 88%. And this remained true on further analyses of the T1A, T1B, and T1C subsets, supporting the concept that pathologic staging from upfront surgery may permit a nuanced approach to adjuvant therapy without a compromise in survival outcomes. De-escalation of systemic therapy with excellent outcomes has been well established in the HER2-positive population. In the single-arm prospective APT trial, HER2-positive cancers measuring less than 3 centimeters were included, of which 91% were clinical T1 and 99% were node-negative. Patients underwent upfront surgery and then received adjuvant paclitaxel and trastuzumab. With this TH regimen, there have been excellent 10-year outcomes reported, with invasive disease-free survival of 91%, overall survival of 94%, and breast cancer-specific survival of nearly 99%. This regimen also confers minimal toxicities, leading this to become the preferred treatment standard for pathologic stage 1 HER2-positive disease. The AFFINITY trial evaluated 4,800 HER2-positive patients and randomized them to receive either adjuvant chemotherapy with 1 year of trastuzumab or to receive adjuvant chemotherapy with 1 year of trastuzumab and pertuzumab. At a median follow-up of 8 years, there has been a significant benefit in invasive disease-free survival noted only in the node-positive subset, again suggesting that there is no benefit from dual HER2-targeted therapy in the pathologically node-negative population. So without evident benefit from neoadjuvant chemotherapy in stage 1 disease, and given the opportunities for de-escalation, the next key questions in terms of optimizing surgical management become, number 1, what is the nodal disease burden among clinical stage 1 patients? And number 2, what is the need for axillary dissection in the triple-negative and HER2-positive subsets? The early studies of nodal disease burden in clinically node-negative disease actually show a mixed bag of data. Listed here are some of the early studies carried out in the 1990s and 2000s, which included patients with T1 to T3 disease, but all clinically node-negative, in which it was found that the frequency of finding heavy pathologic N2 disease ranged from 0 to 13% in the triple-negative subset, and from 14 to 19% in the HER2-positive subset. But again, these studies included the whole gamut of clinical tumor size from T1 to T3, and it is a well-known fact that increasing tumor size is associated with a higher likelihood of nodal involvement. More contemporary studies have also asked this question. Shown here are studies carried out in the 2000s, which included larger numbers of triple-negative and HER2-positive patients. These studies also included both T1 and T2 patients, but these were all clinically node-negative by examination. The frequency of finding heavy pathologic N2 to N3 disease remains extremely low across the board, less than 5%. The frequency of finding any positive nodes in the T1 groups ranges from 9% to 16%. And again, increasing tumor size is associated with a higher likelihood of nodal involvement. Now, while the likelihood of uncovering heavy nodal disease in clinical stage 1 patients is extremely low, there may be a unique value to preoperative identification of triple-negative patients who have occult nodal disease. And the reason is the Keynote 522 trial that I reviewed earlier showed the greatest benefit of the pembrolizumab regimen to be among node-positive triple-negative patients. The use of axillary ultrasound has therefore been proposed for the purpose of identifying patients who may benefit from this Keynote regimen. Dr. Mittendorf and colleagues evaluated 500 patients with T1 to T2 clinically node-negative disease, in which axillary ultrasound was performed at physician discretion in 34% of cases. Among those, the rate of detection of occult nodal disease in the T1C group was 7.5%. In a further analysis of selected patients who had planned ultrasounds, the likelihood of uncovering nodal metastasis in the T1C group was 5%. So while it may be reasonable to consider axillary ultrasound for the workup of stage 1 triple-negative patients, one also has to take into account these relatively low rates of detection, the operator variability, and the likelihood of false positive findings. There is certainly great value to risk stratification and identification of those that may benefit from immunotherapy. From a surgical standpoint, though, the ultimate most key endpoint ends up being the rate of axillary lymph node dissection. And there has been a decreasing use of axillary dissection in clinically node-negative disease. This is largely due to trials such as the ACOSOG Z11, which established the safe omission of axillary dissection in T1 to T2 clinically node-negative patients who have 1 or 2 positive sentinel nodes and are having breast conservation therapy. This trial showed no difference in 10-year rates of disease-free survival and overall survival, with very low, less than 2% rates of regional recurrence after sentinel node biopsy alone. These findings have subsequently been validated and accepted in the mastectomy setting as well. The omission of axillary dissection among clinically node-negative patients with limited nodal disease at upfront surgery has significantly reduced surgical morbidity, with very meaningful reduction in risk of long-term complications such as lymphedema and arm morbidity. When looking at rates of axillary dissection specifically in the triple-negative and HER2-positive populations, data is again limited in the stage 1 subset. Most studies have included both T1 and T2 patients. But listed here are 2 of the more contemporary series that focused on the triple-negative and HER2-positive subsets, in which it was found that the rate of axillary dissection was approximately 15%. Yet again, increasing tumor size is associated with higher nodal disease burden, and the majority of patients in these studies that had an axillary dissection were T2 patients. Overall, though, we see low rates of axillary dissection among early-stage clinically node-negative, triple-negative, and HER2-positive patients. However, with ever-improving systemic therapies, axillary downstaging in these chemoresponsive subtypes remains a proposed rationale for considering neoadjuvant chemotherapy, and the question has lingered about which approach truly minimizes the risk of axillary dissection. We recently compiled our experience at Memorial Sloan Kettering in a consecutive cohort of clinical stage 1 triple-negative and HER2-positive patients who were treated between 2020 and 2022. Among 500 patients, 9% received neoadjuvant chemotherapy, 68% had upfront breast-conserving surgery, and 23% had upfront mastectomy. Per the standard of care, the indications for axillary dissection were any positive sentinel nodes after neoadjuvant chemotherapy, the presence of 3 or more positive sentinel nodes at upfront surgery, or the presence of 1 to 2 positive sentinel nodes at upfront mastectomy not meeting criteria for post-mastectomy radiation. In this cohort, we noted that patients who received neoadjuvant chemotherapy were significantly younger, and they were all T1C, but there was no difference between groups when comparing histology, differentiation, or the use of axillary ultrasound. Overall, the majority of this population was pathologically node negative. In the neoadjuvant chemotherapy group, 4% of patients had micrometastases alone, and 2% of patients had 1 to 2 positive sentinel nodes containing macrometastases. In the upfront surgery groups, 2 and 4% of patients had micrometastases alone, and 8 and 10% had 1 to 2 positive sentinel nodes. The likelihood of finding heavy nodal burden with 3 or more positive nodes in the upfront surgery group was extremely low, less than 2%. And overall, the rate of axillary dissection was 6% after neoadjuvant chemotherapy and 1.7% after upfront breast-conserving surgery and upfront mastectomy. On further analyses, no factors were predictive of axillary dissection, including T1A to B versus T1C tumor stage, tumor subtype, or the neoadjuvant versus upfront surgery approach. Along with low rates of axillary dissection, we also observed a de-escalation in systemic therapy among patients who had upfront surgery. In the triple-negative subset, 100% of those treated in the neoadjuvant setting received ACT, while in the adjuvant setting, 47% received ACT, 36% had TC or CMF, and 10% had no chemotherapy due to having T1A disease alone. In the HER2-positive population, 100% of those treated in the neoadjuvant setting received polychemotherapy and HP, while in the adjuvant setting, 66% of patients received TH alone, 13% received no chemotherapy due to T1A disease, and less than 20% received polychemotherapy and HP. We therefore concluded that axillary dissection was required by less than 2% of clinical stage 1 triple-negative and HER2-positive patients who had upfront surgery, with no advantage of neoadjuvant chemotherapy in further reducing the risk of axillary dissection. There was also a potential for de-escalation of systemic therapy among pathologically node-negative patients. As we look to the future, the arsenal of effective systemic therapies certainly continues to grow, and there is a continued need for risk stratification, nuanced individualization of treatment choices, and identification of subsets that may benefit from treatment de-escalation or intensification. We also await results of various ongoing trials, such as the COMPASS HER2 PCR trial, which are evaluating other opportunities for de-escalation. In conclusion, evidence of benefit from neoadjuvant chemotherapy in stage 1 disease is lacking. Heavy nodal disease burden is rare, and axillary dissection is infrequent in clinical stage 1 triple-negative and HER2-positive patients who are treated with upfront surgery. Axillary downstaging alone is not an indication for neoadjuvant chemotherapy, particularly given that de-escalated systemic therapy regimens do afford excellent outcomes in stage 1 disease, especially in the HER2-positive subset. Continued refinement of treatment strategies will, of course, remain key. Thank you for your attention.
That's excellent. And next we have Dr. Marko Maresevic from Baylor College of Medicine in Houston, Texas, discussing optimizing outcomes in breast reconstruction, technique, and timing after mastectomy.
Hello, my name is Marko. I'm from Baylor, Houston, Texas. I'm just a plastic surgeon. Please, let's set expectations. Not hard rock science. It's going to be a lot of pictures. I want to show you guys what we do in the other side. Oops, how do we? Oh, here. That's here. Okay, no disclosures. I mean, since I don't know any of you, so maybe you know me a little bit more. I'm not from the U.S. I've been training for a long time. I did like 12 years of training and between research, residency, and fellowship. And just during those years, I could witness how the care for breast cancer has changed. And as plastic surgeons, we have to be updated on that for sure. I'm here to talk about breast reconstruction and different types. So we have the total, when you have a flat chest, you have the skin sparing when you save skin, and the nipple sparing when you save the skin and the nipple. So here in my talk, NAC is not adjuvant therapy, it's nipple. So, I mean, if you look at the data, there's, I mean, in the last 5-10 years, there is a lot of data showing the nipple sparing performs better than other types when you use the Q breast for quality of life. You can, I mean, you have papers from all types of journals, from the breast journal, from plastic surgery journals. So I think it is important for us as plastic surgeons, and ideally, we could save the nipple of every patient, but that's not possible or feasible. So sometimes we have to deal with a flat chest when patients not thinking about breast reconstruction at that time, when there's a lack of coordination or you have no plastic surgeon, especially during the COVID time that happened a lot. And when patients need a radiation therapy and they're not interested in tissue expander. So this, by definition, delay reconstruction. So on those types of patients, it's better to use your own tissue than use a tissue expander or a piece of plastic. So I'm going to show you a lot of patients. This is like a 31-year-old female. She had a left mastectomy there. It was a stage 1 cancer, but for some reason, plastic surgeons not involved. OR time was really difficult, but she was found later to have BRCA. So we plan to do a right nipple sparing mastectomy and reconstruct the breast with a DIP flap. DIP flap is a flap that comes from the abdominal wall. But on that picture, you can see how, I mean, you have 2 different types of reconstruction. And the skin pad on the lower pole, we take it out in 3 months later, but you can see how the one in the right will be better for the patient. Despite the fact that you can do a nipple on the left side, but it's never the same. So here we have another patient, it became flat. There's no radiation therapy, which is good. So later on, we do the same procedure. We harvest tissue, we transplant tissue from the abdominal wall to the chest wall, and you can build a breast mount, and later on you finalize with nipple areola reconstruction. Is a quick, I mean, the nipple areola reconstruction is a quick case, can be done as an outpatient. So here she is before and after. Again, we have to finalize her reconstruction, but again, you have a large skin paddle because you don't have a lot of skin from the get-go. Another patient, she had radiation therapy on the right. We're going to take her to the OR. Again, these patients do better with tissue reconstruction. So we do DIP and a contralateral symmetrization at the same time. So this is a tough patient. So you have heavy adjuvant radiation therapy. This becomes very difficult. I mean, that's not ideal for the plastic surgeon. So we take her to the OR and we do, I believe, a very good bilateral DIP reconstruction. But what happens with time is that you have this tissue on the left, which is very stiff and hard, and you have the natural tissue on the right that just falls. It becomes very difficult to make it right. Skin sparing. Skin sparing is when the nipple is very close to the mass or part of. Also patients that don't want to keep the nipple for some reason. And patients that have a large entodic breast also are considered best candidate for skin sparing. But we'll talk more about that. The reconstructions happen at the same time, and you can opt if you want to do autologous or use tissue expander implant-based reconstruction. So this is a 54-year-old female, right breast cancer. So she has toric breast, meaning the nipple is pointing down, no plans for extra T. We take her to the OR, that's the intra picture. We set up our skin paddles, and here she is after one touch-up. So from there, we do a little lift and a nipple reconstruction, and you can appreciate the improvement on the abdominal wall donor side. And here she is with some ink on her nipple areola complex. Right breast cancer, 46. She has a previous breast aug. Also, she does not want to keep the nipple. We're going to take her. This is going to be a two-stage operation because we were still waiting on the final path to decide if she's a candidate for XRT or not. So this is a bilateral DIP on the second stage. She did not need XRT. So we take her back to a bilateral DIP. We set up our skin pads. You can see the improvement on the abdominal wall. From there to there, from there to there. So, I mean, this is a happy patient with improvement on her breast and on her abdominal wall donor side. So how about the nipple sparing? This should be our gold standard. I mean, the neck here, we're going to preserve the nipple. This is, I mean, not every patient is a good patient for keeping the nipple. It's more for the young, things, more breast, non-smoker patient. This is by definition as well an immediate reconstruction. And you can also choose between autologous, using your own tissue, or implant-based reconstruction. I mean, as you guys know, I mean, in the last 5-10 years, we have decreased our threshold for keeping the nipple. I remember when I was a resident, it was like 2 centimeters. Now it's like 1. And I mean, at the discretion of the breast cancer team, but we have definitely seen a lower threshold for that. So here we have a 35-year-old female, small breast, non-thoracic, young, healthy, left breast cancer. So we do a bilateral nipple sparing mastectomy, immediate DIPs. You have the skin pedal there on the lower pole. We remove that in 3 months. This is just for us to watch the flap in the first 48 hours to make sure that the blood vessels are open. So here she is before and after. I mean, she can walk around and no one can even tell that she had breast cancer. This is a 52-year-old female, left breast cancer. So she, in that case, she does not want to use her own tissue, so we go to a direct-to-implant reconstruction, so at the same time. And here we have her in follow-up. After one touch-up, she wanted to upsize her breast implant. Before and after, also a happy patient. 25, small-breasted, non-thoracic. This is a direct-to-implant as well. 47-year-old female, left breast cancer. So here the breasts are more like a B, C cup, a little thoracic. We go for it. You do a bilateral nipple sparing mastectomy and immediate DIPs. You can see that the skin here suffers a little bit more. It's not because of the breast surgeon, but likely because her skin, she had a lot of skin. So nevertheless, she did very well. The skin and nipples suffer a little bit, but she's overall very happy. So the question is, how can we avoid and minimize this? I mean, the suffering of the skin. So we propose, and this has been like a hot topic in plastic breast surgery in the last maybe 5-10 years, maybe 5, is to do a stage procedure. So the goal of the stage procedure is to make the patient more eligible for nipple sparing. So delaying the skin flaps and the nipple areola complex. So in the first stage, we do a breast reduction lift. We really insult those skin flaps so they can live on their own. And then we wait in between 6 and 12 weeks and do a nipple sparing mastectomy at that time. These are patients, of course, where the nipple is not part of the cancer, not closed. BRCA patients, stage 1 cancer, and of course, not smoker, not obese. And those patients that had thoracic and large breasts now become candidates for nipple sparing. And here also you can opt to do autologous, your own tissue, or implant-based reconstruction. And here, I mean, you have papers showing, good data showing that there is a decrease in complication rate, especially on the wound healing, the nipple and the skin making it when you do this approach. So you do a reduction and lift, you wait 6 to 12 weeks, and then you do your nipple sparing mastectomy. So here you have a 42-year-old female, right breast cancer stage 1. She wants to keep the nipple. She's adamant about it, and she wants implant-based reconstruction. So on October, we do a right lumpectomy, lymph node biopsy. I do the right oncoplastic mastopexy, which is a lift, and we do a left pexy as well. 3 months later, we come back and we do the nipple sparing and a direct implant reconstruction with ADM, which is a biological mesh. So here you have before and after. Patient is happy. I mean, you can see the position of her nipples is higher. And if you not have done that mastopexy, the breast lift first, the implant will be sitting high on her chest wall and the nipple looking down, and she'll be unhappy. So that's the reason for us doing this stage procedure. Here you have a BRCA patient, 59. She wants to keep her nipples a little tonic. So we do a stage breast reduction and lift. We wait 3 months. And we plan for a bilateral DIP, which is the tissue reconstruction from the abdominal wall. Here she is in the OR. We keep those, again, the skin pedal there in the lower pole for 3 or 4 months. And here her follow-up after 1 touch-up, 1 revision, and before and after. So she's very happy with her abdominal wall, and her breasts look, she likes her breasts very much. More challenging patient, higher BMI, but it's still doable. She comes, she knows everything about breast reconstruction. She's part of the breast cancer support group. She wants to keep her nipple. She's very adamant about it, and she wants a DIP. So stage 1, we do oncoplastic lift, symmetrization. She's a stage 1 breast cancer. So we come back later, I think in 2 months or so, 6, 8 weeks. So we harvest the tissue from the abdominal wall. We bring to the chest wall. We do our microvascular anastomosis. And here she's in follow-up. So we're able to preserve the nipples. She got a breast lift, and also an improvement on her abdominal wall donor site. Here, before and after, before and after. Another challenging patient, BRCA patient. She has stage 4 ovarian cancer, but is healthy. And again, adamant about keeping the nipples. She's a little bit overweight. We do a reduction first, we wait 8 weeks, we come back, we transfer tissue from the abdominal wall, touch up, follow up, before and after. So these are strategies that allow us to make patients that were not before eligible for nipple sparing to be patients that are eligible for this. Another topic that I want to mention very briefly is a sensation of the reconstructed breast and nerve reconstruction during that. So we have 2 approaches. One is neurotization of the flap, which is the DIP flap that comes from the abdominal wall. In the other scenario is what we call a nerve-sparing, nipple-sparing mastectomy, where we do the neurotization of the neck, the nipple-areolar complex. And I mean, in the last 5 years or so, you see a lot of papers talking about it and showing data that is optimistic. So here we have a patient, a 48 female, left breast cancer. She has lymphedema as well and XRT. So the plan is to do neurotization of the flap. So these are the markings of the flap. We're going to bring some lymph nodes as well, okay? Because she has a lymphedema and she had axillary dissection on the right side. So here we're raising the flap, and this is a sensory nerve. This sensory nerve I'm going to take with me and transfer to the chest. So here you have the pedicle, the vessels that goes to the flap, which is the tissue, which is the skin and the fat. You have the nerve, and you have the lymph nodes that you're taking from the groin to transfer to the axilla. Here you have the chest wall. You have the memory vessels and the intercostal nerve they're going to use to coapt our nerve and do our microvascular anastomosis. So I'm going to take you to my OR. So a tour. Here you have the vessels pumping. This is going to be the blood supply of the tissue. And there on the lower part, you have the nerve. And as an extension of the flap, you have the lymph nodes. Not a lot of them, but some that are going to help us treat the lymphedema of this patient. So here we go to the chest wall. You see our intercostal nerve. We're going to transect that and coapt with the nerve of the flap. And we have the artery and the vein that are going to be used for our microvascular anastomosis. And here we have the inset. We have to position in a way that the nodes are going to end up exactly where we want in the axilla. At that time, I have done our microvascular anastomosis already, so we have good bleeding, which means the tissue is alive. So here she is intra-op, and here follow-up. We did already her nipple, but I couldn't find a picture. She's a very heavy patient. Similar patient, so DIP, the flap, the nerve of the flap, and here is the nerve on the chest. We can find this nerve on the intercostal space, usually the plastic surgeons do, but here is a nerve that the breast surgeons find for us. Is lateral to the pec major muscle. And here you have the coaptation of the flap. The other approach is to do a nerve-sparing nipple-sparing mastectomy. Also, a lot of, some papers came up in the last 5 years about that. So here we have a 42-year-old female, left breast cancer. She wants to keep her nipples, and we plan to neurotize her nipple as well. So here you have nipple-sparing mastectomies. And here you have those nerves that I just talked about. It's lateral to the pec major, is the fourth intercostal nerve that is responsible for the innervation of the nipple areolar complex. So we're going to find the nerve that is behind the nipple, and this can be tricky a little bit. And we're going to use a nerve graft. You can use a nerve graft, this is an allograft, but you can use a nerve graft from the patient as well, but it's difficult to find a donor site, but it's possible. But here we find we are going to use a nerve allograft. Here's the other side. So this is going to be a direct to implant reconstruction, okay? So here you have the biological mesh wrapping the silicone gel implant, and you have now the nerve coapted. So the intercostal nerve is again connecting with the nipple areolar complex. So that's her intra-op picture. And that's before and after. So early follow-up, you can still see like the mag seed staying there on the left breast. Patient also very happy. So I'd like to thank you, my breast surgeons at Baylor, and I'd like to thank you for your attention. Thank you.
Thank you. What great discussion. So we're going to move on now to questions. So if you have questions, you can come to the microphone or submit online. My first question actually is going to be to our plastic surgeon. Oh, and I'm sorry, let me also introduce Jamie Lascala, who is from the Translational Center of Excellence in Breast Cancer from Penn Medicine, Philadelphia, Pennsylvania, who is our patient advocate representative. Thank you for joining us. So my first question is to our plastic surgeon. You know, as we talk about issues and controversies, we talked a lot about post-mastectomy radiation. Obviously, you're trained in microsurgery. You do a lot of DIEP flap reconstructions. I'm aware that last year, Medicare changed how they pay for DIEP flap reconstructions. They sort of sunsetted the code, so it reimbursed the same as the tram flap, and that commercial payers have kind of followed that also. Do you find that now that in the last month Medicare has reinstated that code, that if commercial payers aren't paying for it, is this still an option for the patients that you see?
Can you hear me?
Yeah.
Yeah. So yeah, you are right. In the last year they changed the code, but we got it back. So I think. I mean, DIP flap is a flap that is very difficult to do. It takes like hours. And I think if the reimbursement is not very good, a lot of plastic surgeons will not do them and will just do like implant-based reconstruction. And in some cases, like I show you, with heavy radiation therapy, it's not the ideal reconstruction. The ideal reconstruction on those patients is most of the time is to bring some healthy tissue from the abdominal wall or from the thighs.
Thank you. Lots of questions about management of the lymph nodes. So first, to my surgeons, how do you handle the practical issues of 1 out of 1 or 2 out of 2 sentinel lymph nodes that are positive? Do you demand 3 lymph nodes up front, or do you send the patient back for additional sentinel lymph node biopsy? And is that answer different after neoadjuvant therapy?
Is the microphone on? In Z11, so in the upfront surgery setting in Z11, there was no requirement for a number of sentinel nodes that had to be removed. So if you had 1 of 1 sentinel node, that's adequate, and you do not need to go back to try to get more nodes. You have what you have when you're doing a sentinel node biopsy. In the neoadjuvant setting, as I said, any positive sentinel node after neoadjuvant chemotherapy, until the ongoing clinical trials are published, requires an axillary dissection.
This is related to another question, is that also true if you're IHC positive?
That will be discussed tomorrow in the general session.
Dodge. Okay, can we come here to the first microphone?
Thank you for a great discussion. My name is Karin M., general medical oncologist. I wonder about evolution of axillary lymph node dissection over the last 15, 20 years, as far as previous and current number of lymph nodes removed and the other aspects of surgery with incorporation of neoadjuvant treatments. Thank you.
Are you asking if the technique for axillary lymph node dissection has changed?
More so the number of lymph nodes. Has that gotten down with dissection? Are you removing less lymph nodes?
No, I mean, I think I think that there's a lot of variation on how different people do axillary lymph node dissection. I think most of us, unless the patient has advanced disease and disease high, are not going to do a level 3 dissection. So most of us will do a level 1 and 2 dissection. But when I'm doing it, I do it the same way we do an en bloc resection of the entire axilla in level 1 and 2. In the neoadjuvant setting, sometimes you do see fewer nodes. I don't know if because of the response rate and things like that, that some of the nodes will just be so small that you really can't identify them. But typically the number of nodes that we see is about the same as it was in the past.
And I'll just add, this is an anatomically performed procedure, so performing that within the defined anatomic boundaries will yield the number of nodes that are there. And as Andrea said, that number is not different now than it was in the past.
I'm going to go to the online question again. This is from Regina Rosenthal for our radiation oncologist, and then I'd love a comment from our patient advocate. Do you have any comments on situations where you feel partial breast irradiation appropriate for selective invasive lobular cancers? And then as a follow-up from our patient advocate, do you feel like this is advantageous for patients if it's medically appropriate from your doctor? So maybe starting with the radiation oncologist.
Sorry.
Are there some patients where partial breast irradiation would be appropriate for some selected lobular histology cancers?
Selective, sorry?
Partial breast radiation for some selected invasive lobular cancers as opposed to ductal?
Oh, yeah, of course, lobular is something completely different, unfortunately, and we absolutely need studies specifically on lobular cancer. This is in general terms. Of course, this is not a full contraindication, of course, but, lobular cancer is something specific of the breast. So in my personal opinion, partial breast irradiation, it's not the primary approach for this kind of tumor. That can't be 100%, of course, but it's not my primary choice for this patient. We really do need studies on lobular cancer in general.
Okay. And for our patient advocate, do you see any advantages to partial breast radiation for patients in medically appropriate cases?
From a patient advocate perspective, I mean, it was great to hear today about the innovation and tailoring treatment to patients, but certainly, you know, when it's safe to do so in terms of de-escalation, it sounds like we're not there yet.
For lobular cancers. Helpful to have new guidelines, so I appreciate you sharing those. Can we go to the microphone over here?
Thank you for those wonderful presentations. Thompson from Houston. Could I ask, from a plastic surgeon point of view, is it best for the plastic surgeon to start the surgery when doing the reduction and lift and the lumpectomy at that same time? So you place the incisions for the breast surgeon to use? And then secondly, maybe for radiation oncology as well, the advantage of the reduction and lift and lumpectomy first is if the patient is node positive, you can then irradiate before going on to do the nipple-sparing mastectomy. Does that make sense?
Thank you, Dr. Thompson. Yeah, I think it's very important for us to work as a team. I think having the plastic surgeon involved at the time of the and doing the oncoplastic closure and the lift and if necessary, take a little bit of breast tissue is going to be a great setup for the next step. I mean, the case goes faster as well. We get to talk to each other and catch up, and I think it's the best for our patients as well.
Yeah, if I can add, really, I think we have to move from the multidisciplinary as a word that's used in Congress as a word used in the real practice. That is something that we are obtaining, of course, with multidisciplinary team, but here really you can see the effect, the practice effect of a multidisciplinary, to discuss at the very first moment within all the professionals in order to know in advance where radiation therapy is planned or not, and to decide together the best approach for our patient. This is real multidisciplinary thing. We have to work on that.
Thank you.
This question is for Dr. Meattini. If an elderly patient is less than 65, refuses an aromatase inhibitor, would you still offer accelerated partial breast irradiation if you think they won't get appropriate endocrine therapy?
Yes, okay. Definitely. The best radiation therapy, of course, the less minimal, but yes, of course.
Thank you. Let's go to the microphone over here.
Hi. So in a neoadjuvant setting, axilla node, we try to get 3. And in a situation that the patient have a positive node, of course, and have a marker in, and then we remove it. And I can only find 2 sentinel node, but that marker, the clip node, is not sentinel node. So could that count as a 3rd node, or I still have to proceed to do full dissection for that patient?
I just want to make sure I have your question correct. You're saying that you got the clipped node out?
Yes, the Pieris positive node is clipped, right? By localizing and remove it, but that one was not hot or blue.
Yeah, so when we think about sentinel node biopsy in the neoadjuvant setting, we're really just trying to minimize the false negative rate. And I think there are several strategies to do that. One is to get 3 or more sentinel nodes, and another is to do TAD, get the clipped node, and do a sentinel node. And if you do targeted axillary dissection and get the clipped node, there is no requirement for the number of sentinel nodes you need to remove. And I think if you feel comfortable with your results, the axillary dissection would not be needed if your nodes were negative.
Thank you.
Dr. Barrio, this is a question for you also. The role, or for our surgeons, the role of axillary reverse mapping is growing. so possibly no longer a binary decision with sentinel lymph node biopsy versus axillary dissection. Selective axillary dissection with ARM can preserve nodes draining the axilla so the lymphedema risk is minimized. So goal to do a smarter axillary surgery to achieve the oncologist's goal with minimizing morbidity. Hopefully Allison's trials will further support this approach, but they would appreciate your opinion if you feel like this is a relevant approach to patient care at this time.
We don't currently do axillary reverse mapping at our institution. I think we have kind of gone to immediate lymphatic reconstruction after axillary lymph node dissection, given the good results that we saw. I think the Alliance trial, I agree, will be very helpful in understanding if ARM does reduce lymphedema rates, but I can't make much more of a comment than that because we don't routinely do it at our institution.
Thank you. Let's go to the microphone over here.
L. Tamer, Sloan Kettering. For Dr. Maricevic, you're talking about nipple sparing with nerve sparing. And our main purpose of a nipple sparing mastectomy to remove as much as possible breast tissue. When you try to save that nerve, if you're not doing nerve bypass, you're just saving the nerve, what is the chance of leaving breast tissue behind?
Can you repeat the question? The audio here is...
The extent of residual breast tissue when you perform a nerve-sparing, nipple-sparing mastectomy.
How much residual breast tissue do you have?
How much does it take?
How much residual breast tissue might remain in the patient when you do nerve-sparing and nipple-sparing mastectomy?
Sorry, I see.
How much so...
Okay, yes, thank you. Sorry, the audio here is not
okay.
very good. So I think when we find the nerve lateral to the pec major, the intercostal nerve, the breast surgeon is going to dissect the breast from medial to lateral. And when you're lifting the breast, you can see the nerve coming up from the lateral border of the pec major. And at that point, we do dissection under loop magnification. So we don't leave any tissue there. We eskeletonize the nerve completely. And you can get a length of like 8 centimeters, sometimes 9, 10. The tricky nerve to find is the nerve behind the nipple, because the breast surgeons have to remove tissue from there. And that's the time that also I use my loop and we look very careful the nerve. Sometimes we do not find the nerve, and we just spread the fascicles of the nerve graft and we attach that to the skin. But the tricky part of the procedure is to find the nerve behind the nipple, but we don't leave any residual breast tissue because of it.
And how functional is this nerve? Have you done studies on sensation in the nipple and the chest after this nerve sparing or nerve reconstruction?
Yeah, the data is very early. I mean, we don't have long-term follow-up at all. I mean, this is a procedure that literally we started to do like maybe 3 years ago. So the data is still not there. We don't have long-term follow-up. But as far as we know, there's no like drawback of doing it. So we are trying our best to improve the sensation of our reconstructed breast.
Thank you.
Thank you.
A related question that we have online is, are you seeing an increased interest? I'm interested in your opinion and also our patient representative's opinion, an increasing interest in nerve-sparing and nipple-sparing mastectomies among the patients you serve? For both of you.
Yeah, I can say the answer is yes. Yes.
What percentage of the reconstructions do you do in this year do you think had those offered?
Nerve sparing?
Yeah.
Maybe 2 patients.
Okay.
But once they know about it, I mean, it becomes like there's no reason to decline.
And just from a patient perspective, I would think, for patients to be able to, keep their nipples and, potentially with the other innovations to have potential reinnervation or the sensation, I think would be great for quality of life.
Okay.
Yeah, in the discussion with the patient, just to be clear, is that I will not try. I cannot promise it's going to happen. We're trying to find a nerve. I mean, all the stars have to align in order for us to succeed.
Okay. Thank you. Another question that's come up is if you have patients that are clinically node 1, receive neoadjuvant chemotherapy, and the sentinel lymph node is negative at the time of surgery, or they have a pathologic complete response after neoadjuvant chemotherapy, do you feel like you can avoid radiation in that patient population safely? And does it differ by breast cancer subtype?
We will find out tomorrow.
This is a common answer I'm hearing. Okay, let's go to this microphone over here.
Yeah, thank you. Thank you for a great session with some really stellar presentations. So I've got a question really for Andrea and Anita. I'd like to know how you further manage the axilla in patients who have fibrosis only in 1 or 2 sentinel nodes after induction chemotherapy without any viable tumor, both in the context of clinically node negativity at presentation and also those who are biopsy-proven node positive.
Do you mean when they have treatment effect in the nodes?
Yeah, when there's fibrosis within the nodes.
Yeah.
So, many pathologists will confidently tell you that if there's fibrosis in the node, then that node probably had been sterilized and was positive, before chemotherapy. So, for example, those who are clinically node negative at the outset, would you advocate axillary radiation in most of those cases rather than no further axillary treatment?
At the current time, we often do. If they were clinically node positive, and then if they had treatment effect. But as we said, we'll know more about that tomorrow.
Okay, thank you.
Let's go over here.
Thank you. Thank you for a great session. Shelley Feldman from Montefiore, New York. So for the radiation oncologist, that's great to talk about patient-friendly approaches, partial breast irradiation. So you failed to mention probably the most patient-friendly approach, which is now in the new ASTRO guidelines as approved if it's done as part of a trial, which is intraoperative radiation, where patients receive a single dose of radiation at the time of surgery. And in many studies that have now been published, 85% of the patients do not need any additional radiation. So I'd like your opinion about that.
Concerning partial breast irradiation in general, of course, I know. First of all, partial breast in general is a clinical indication. This is really, it's an appropriate indication. So this is my personal opinion. Concerning technique, it's something different, of course. You know all about the IRT studies that has some implication, not only, of course, in terms of selection of patients, but basically there were 2 negative trials. So you have really to take in account your decision. It's based also on your expertise, of course, but basically the most robust data in terms of equivalent control is in favor of brachytherapy or external beam brachytherapy. I am the first one that is not in favor of an indication related to a technique, because I'm a clinician, first of all, but you have to take in account the existing level of evidence that is a bit more unfavorable concerning the intra-op trials. But it's not something related to technique,
Right, but I think in a session on partial breast irradiation, when ASTRO has an opinion about it that can be done as part of a trial, to not even mention that, it seems like an omission if you're talking about a patient-friendly approach. I think I'd be interested to hear the advocate. So patients who opt for this approach, where they have their lumpectomy done, they have a single dose of radiation done during the surgery, and the majority need no additional radiation, and the vast majority of the patients do very well. There's some healthy debate about the local recurrence difference depending on the technique. There are studies both ways, but I think it needs to be mentioned at a session like this. Thank you.
Yeah, I agree with your comment. Thanks.
So I'm going to take up one last question, and this deals with, I think, an important issue in this session regarding when we have mastectomy and anticipate post-mastectomy radiation. Do you have an optimal reconstruction choice And in the event that you are doing an implant-based reconstruction, do you have a protocol for deflation of the contralateral expander for PMRT? This person's, Sumita Bhatia says they were told it creates seroma and infectious risk. So first, a protocol for reconstruction. What reconstruction would you favor in the setting where you anticipate PMRT?
Yeah, every time there is radiation involved, I always lean towards tissue reconstruction. Because I think it's better. The implant depends a lot on the quality of the skin and tissue. And after radiation therapy, that is not very reliable. I know there are different types of radiation, different regimens, but my experience during training and with my own patients is that I tend to lean towards autologous reconstruction. And regarding the deflation of the tissue expander, is up to the radiation oncologist. I'm gonna do what I'm told.
And do you have a preference? Like, as a radiation oncologist, do you have a preference of if someone has expanders placed for an implant-based reconstruction around deflating them? Does it depend upon a woman's body habitus or breast contour?
I have no specific preference. There is no data that favors something or another. And of course, the discussion is really important with the plastic surgeon, but we are aware that not all the patients that are candidates to receive post-mastectomy radiotherapy can receive an autologous reconstruction. So it's here the multifactorial discussion, the expectation of patient, the kind of patients, other comorbidities factors and so on should be taken account in the decision, I think, because otherwise it's impossible.
Thank you. What a wonderful discussion. Thank you all.